I wanted to highlight four main differences for patients who receive lung transplants from Ecmo. The first is that whereas normally we deal with patients who have chronic stable conditions, who are on a waiting list for lung transplantation at home, once those patients have been placed on Ecmo, in general terms they're hospitalized, perhaps ventilated, unable to maintain their normal physical condition and nutritional status in such a straightforward manner. And one of the really important things for lung transplantation to be successful is that after the lung transplant operation, patients are strong enough to breathe, to wean from the mechanical ventilators in an early manner, and to mobilize early. That certainly improves outcomes. And for patients who've been deconditioned because they're in hospital, tied down to a bed by machinery, that's difficult. So an important feature is to have a good active physiotherapy team helping to rehabilitate patients before they come through to transplantation. The second issue is that the surgeon faces a variety of complex cannulation techniques, which may result in vascular complications such as venous thrombosis or arterial injury. We may see other complications such as retroperitoneal hematoma and other vascular injuries which require repair at the time of the lung transplant operation. In addition, the cannulation may need to be changed to maintain a stable cardiopulmonary bypass circuit or Ecmo circuit for the duration of surgery, so that the surgeon is technically able to access the various structures he must do. The third difference is that there are a number of hematological issues that arise. Patients who are on Ecmo often require repeated blood transfusions, which may result in high levels of HLA antibody sensitization and may render patients untransplantable. Issues such as hemolysis are also seen, and this can convert chronic renal disease into chronic failure requiring hemodialysis, therefore affecting the candidacy for transplantation. And the fourth and final difference that I want to highlight is that in general terms, when we do elective lung transplantation for patients from a waiting list, they have a stable pathology. When we're transplanting patients from Ecmo, we're dealing with acute phase pathology, and this increases the number of complications such as hemorrhage, bleeding with hemothoraces, bleeding with dense inflammatory adhesions. So it can make this surgery technically much more demanding, and in turn that means that the outcomes can be impacted. So in summary, I would say that Ecmo is a useful tool for bridging selected candidates to lung transplantation. However, it's important not to embark upon extracorporeal life support unless there is a realistic chance of maintaining candidacy. Ecmo has to be targeted to maintain the patient in the optimum condition for lung transplantation so that the chance of successful outcome is maximized. Thank you.